Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. What I'm going to be sharing with you today is a nice and typical example of a rare tumor yet very well characterized. This is angiocentric glioma, CNS WHO grade 1. This is a case of a 3-year-old male patient who presented with seizure and was found on imaging to have right temporal lobe lesion. So the lesion was excised in total. And as you can see here from the low power magnification, what really catches the eye is the prominent vascularity, and then we have like a rarefaction in the background. So zooming in a little bit into intermediate power magnification, again the vessels are very prominent, but what we start to see are those entrapped normal ganglion cells. This is why the patient presented with seizures, because there is involvement or infiltration of the tumor into the cortex, causing the seizure. So the neurons that are entrapped are normal appearing neurons. This is extremely important so that not to misdiagnose the case as ganglioglioma, for example, in which the ganglion cells are usually dysplastic. These are normal looking cortical neurons. Now in the background, we can see some spindle cells, but going again into the second important component of the tumor, which are the prominent vessels. And the vessels are prominent because these are all, regardless of the size of the vessel, big or small, cuffed tightly by tumor cells. And on high power magnification, this is the vessel, and the vessel is wrapped really very tightly cuffed by the tumor cell nuclei, which are either perpendicular or sometimes even parallel to the luminal or to the wall of the vessel. And we can see this pattern repetitive over and over in almost all vessels that are identified within the tumor cells. Now mind here that in contrast to the ependymomas or pseudorosettes of in ependymomas, there is no clear nuclear free acellular zone that separates the tumor cell nuclei from the vessels. This is a very important subtle clue because the tumor cells appear to directly hug the vessels, causing these vessels to become very prominent. In other areas, as if you see here, reverse polarity, where the processes of the tumor cells are actually pointing away from the lumen of the vessel, whereas the nuclei are the ones which hug the vessels. And this is why we see this prominent vascularity in the tumor. Now into the tumor cell nuclei in general, usually these are arranged either infiltratively into the cortex, as I shared with you, or sometimes showing this story-form growth pattern that is in a way reminiscent of the dermatofibroma kind of a tumor. And on high power magnification, regardless of where we zoom into the tumor cell nuclei, these are spindle in shape with the processes in a way reminiscent of pilocytic astrocytic tumors, long processes with oval-shaped nuclei, inconspicuous nucleoli, and no evidence of mitosis. Now, in yet other areas, we can see entrapped neurons and abundance of myxoidish background, yet the tumor cell nuclei retain the same appearance. This spindle nucleus that is very vesicular, inconspicuous nucleoli, abundance of a fibrillary cytoplasm in the background. That the tumor cells typically stain positive with GFAP, and mind here the intensity of the staining of the tumor cells that hug the vessel. And again here, wherever you go, the tumor cells are positive. These are the processes, the long processes of the tumor cells, and this is the cytoplasm, and this is one of the entrapped neurons that is negative with GFAP. All symbolic. 2 typically is negative. These are the nuclei of the neurons or some normal cellular component, whereas typically the tumor cell nuclei that are shown beautifully here as spindle-shaped are negative. Now, surprisingly or not, EMA is also positive, showing dot-like cytoplasmic staining, especially in the tumor cell nuclei hugging or surrounding the tumor, the tumor vessels. And this is why this is quite similar morphologically as well as immunophenotypically with ependymoma. However, with the neurofilament protein, there is extensive infiltration into pre-existing brain structure, which really contrasts with typical ependymoma. Ependymoma is typically a well-circumscribed tumor that does not show evidence of infiltration into the background brain. And the new immunohistochemistry highlights the nuclei of the entrapped normal ganglion cells or neurons, and the Chi67 is extremely low, less than 1%, because this tumor is not mitotically active. So the final diagnosis in this case is consistent with angiocentric glioma, CNS-WHO grade 1. Remember that this tumor typically involves the cortex, and the typical presentation is with long-standing epilepsy. Despite being infiltrative, this tumor is assigned a CNS-WHO grade 1 because of the indolent behavior and the long-standing tumor. Once the tumor is excised, the patients usually are cured from seizure, and there is no need to give any further treatment. Remember that the enhanced vascular pattern, this is why it's called the angiocentric, because of the way the tumor cells hug the vessels, make this very angiocentricity very peculiar to this tumor type, and makes the vessels or the vasculature of the tumor very prominent. Remember that there is no cellular zone separating the nuclei of the tumor from the lumen of the vessels. This is why this contrasts with ependymoma. And remember that ependymoma usually is circumscribed tumor, whereas angiocentric glioma is an infiltrative tumor that can be further highlighted with a neurofilament protein. So despite similarity to ependymoma, somehow morphologically and by immunophenotype, the tumor is completely separate from ependymoma, at least as far as the evidence that we have until now, and it is assigned a CNS grade 1 tumor. I hope you find this tip useful in your daily practice. Thank you.